First speaker, Dr. Tova Gardin is a clinician scientist at the Yale School of Medicine and Chief Translational Officer at Biohaven, a biotechnology company focused on advancing innovative therapies for immunologic, neurological, and neuropsychiatric diseases. Dr. Gardin earned a Master of Public Policy degree from Princeton School of International and Public Affairs, focused on domestic health policy. She attended Harvard Medical School, where she graduated with honors in research. Her research during medical school investigated imaging biomarkers in psychotic illness, laying the foundation for her future work in autoimmune encephalitis. Following medical school, Dr. Gardin completed dual residencies in psychiatry and neurology, served as clinical chief resident, and completed fellowship in neuroimmunology at Yale. During this time, she was awarded an NIH R25 Development Award to study transcriptional profile at the single cell level in autoimmune disease affecting the central nervous system. She is board certified in both neurology and psychiatry by the American Board of Psychiatry. Following the completion of her training, Dr. Gardin founded and served as the inaugural director of the Yale Autoimmune Encephalitis Program. Under her leadership, this program was designed to bring together multidisciplinary teams skilled in neuroimmunology, psychiatry, and molecular biology to provide cutting-edge, patient-centered treatment and research for individuals with autoimmune encephalitis. In her role as Chief Translational Officer at Biohaven, Dr. Gardin leads the company's innovative translational research programs, including their groundbreaking molecular degradation and targeted protein degradation degrader platforms. Under her scientific leadership, Biohaven has achieved remarkable success with their lead compounds, BHV 1300 and BHV 1400, demonstrating unprecedented selectivity and efficacy in targeting disease-causing proteins. And today she's going to talk with us about From Synapse to Syndrome, Mechanistic Insights and Translational Advances in Autoimmune Encephalitis. That's all yours, Dr. Gardin.
Dr. Leflin, thank you so much. It's such an honor to be here presenting for the GW Neurology Department. I have tremendous regard for Dr. Leflin, and I'm excited to share a bit with you about autoimmune encephalitis today. So this is certainly an area that is near and dear to my heart, as Dr. Leflin mentioned. In terms of my disclosures, I am the Chief Translational Officer at Biohaven, as Dr. Leflin mentioned, also a faculty member at the Yale School of Medicine. Autoimmune encephalitis, it's a rare disease, but the numbers are growing. So in 2021, we said that about 4,000 people in the United States were getting diagnosed every year, but this number is growing. We think of it as a generally somewhat benign condition, but actually over half of patients with autoimmune encephalitis are admitted to the ICU, and almost a third of them relapse over time. The number of autoantibodies that we know about is growing astronomically, particularly with high throughput techniques. In the early 1980s, antibodies like anti-Yo were discovered, which were targeted against intracellular antigens. This gave way to the early 2000s, when a new set of antibodies were discovered that targeted antigens that were extracellular or to surface receptors. I'm going to take a moment and turn this to a case, because oftentimes when you're sitting at the bench, things look really clear. Antibodies look clear, spatial and single cell transcriptomics look clear, but when you're looking at a patient and you're hearing their story, it's often not so clear. And so particularly for the sake of the residents in the room, I'm going to go ahead and turn this to a clinical case so you can see that the murkiness of the clinical case ultimately turned towards the clarity of the molecular science. This is one of my own patients. So her name has been changed for the sake of the case, but Sam was a 19-year-old nursing student when she first presented. She had no past medical history. And on August 12th of 2020, she began to hear music in the background. 16 days later, she went to sleep with a headache and woke up in the morning in the hospital having had a seizure. Her MRI was pretty nonspecific. So she had this single T2 flare lesion. It was non-enhancing. And given her age and her lack of past medical history, it was thought it was probably due to migraines. She was discharged from the emergency room. It was her first seizure. She went back to school the following day. But 4 days later, the music just kept getting louder and louder. And she started feeling like the world was shifting around her. She began to experience zaps up and down her left sides, and at times with contracting of her left hand and an intermittent speech arrest. This happened repeatedly, and on September 11th, she returned to the emergency room. At that time, there was suspicion that she was having seizures. She had an EEG, which indeed demonstrated seizures and was started on Keppra, causing the seizures to resolve. She had an LP done as well, and this showed 232 nucleated cells, predominantly lymphocytes, 8 red cells, a normal protein. Her HSV was negative. And she had oligoclonal bands drawn as well as the autoimmune encephalitis panel. Both were pending at the time of discharge. She was discharged on September 13th with a plan to follow up in the neurology clinic in October. The next day, though, she began to notice that her speech was slurred. So she called the emergency room, called the neurology clinic. She was told it was probably due to her Keppra, and they recommended holding a dose. And then the following day, she presented again with a bilateral tonic-clonic seizure to the hospital. So I want to pause for a moment because we have fantastic antibody testing. I don't know if the same is used at GW, but at Yale, we use the Mayo testing, which is great. It takes some time to come back. And there's often a misconception that you have to wait for the antibody testing to come back positive in order to diagnose NMDA encephalitis. And so I want to take a quick moment and step back and talk about a diagnosis of probable NMDA encephalitis. In order to be diagnosed with probable NMDA encephalitis, you have to have rapid onset, which is really typically subacute. So sometime within the last 3 months, a development of at least 4 of 6 major groups of symptoms. So abnormal psychiatric behavior or cognitive dysfunction. In the case of my patient, her hearing music. Again, much clearer on the page, less clear when you're seeing the patient, and she says she's hearing music. Speech dysfunction. In her case, at this point, this was sort of a slurred speech. Seizures, which she had, movement disorders, dyskinesias, rigidity or abnormal postures. At this point, she had had dyskinesias as well. A decreased level of consciousness or autonomic dysfunction or central hyperventilation. And then in addition to the subacute onset of 4 of 6 of these group of symptoms, you have to have at least one abnormal laboratory test. And that can be an abnormal EEG, which she had, a CSF with pleocytosis or oligoclonal bands. At this point, she had a CSF with pleocytosis. Her oligoclonal bands subsequently came back positive. And in addition, you may or may not have a teratoma. So again, at this point, even in the absence of the NMDA encephalitis testing, the antibody testing, she could have been diagnosed with probable NMDA encephalitis, which she was. She underwent five days of steroids, got plasma exchange. It was only on September 23rd, which was a month after she initially presented, that her NMDA antibodies came back positive in the CSF, negative in the serum. She was started on rituximab, which takes some time to work, got IVIG. Her seizures were ultimately brought under control with Depakote and Onfi, and in November of 2020, she was discharged to rehab. I saw her last in 2022, so about 2 years after her initial presentation. And at that point, she'd returned to school. She still had some attention and memory issues, but largely was doing okay. Sam's presentation, although seemingly murky, this woman who presents hearing music, who eventually has a seizure, who comes back with dyskinesias, she eventually developed catatonia, seems unusual, but it's actually fairly classic for NMDA encephalitis, where you have this sort of initial couple of weeks of psychiatric symptoms, maybe seizures, that then leads to sort of weeks to months of neurologic complications. I mentioned at the beginning of my talk that over the course of the 1980s and 90s, there was discovery of antibodies that targeted antigens that were intracellular. And in the 2000s, this shifted to the discovery of antibodies to antigens that were to surface antigens or receptors. NMDA encephalitis was one of the earliest neuropsychiatric diseases with an antibody associated to a surface receptor. And initially in 2005, the cases were described of 4 women who had neuropsychiatric symptoms and an ovarian teratoma. And it was subsequently, in a paper by Dalmau in 2007, he identified that these antibodies, when co-cultured with neurons, bound, or with HEK cells with the transfected NR1 and NR2A or NR2B, these components of the NMDA receptor, they would immunofluoresce. Again, sort of identifying that the antibodies in these patients with this syndrome of teratoma plus neuropsychiatric symptoms, that they had antibodies that bound to the NMDA receptor. Unlike in many of the neuropsychiatric syndromes that have been described with antibodies associated to intracellular antigens, in NMDA receptor autoimmune encephalitis, the antibodies to a receptor or to an extracellular antigen are pathogenic. And the way that we demonstrate pathogenicity is both through in vitro culture systems as well as through passive transfer models or in vivo models. So what you'll see in the upper left here is that antibodies from patients with NMDA receptor encephalitis, when co-cultured with rat neurons, ultimately lead to an internalization and a reduced density of the NMDA receptor. In the cartoon on the right, you see the antibody cross-linking the receptors, resulting in an internalization. Beneath that, what you see is a passive transfer model. So when the antibodies are transfused into the ventricles of a rodent, they similarly result in cross-linking of the NMDA receptor and internalization, decrease long-term potentiation, and memory deficits in these rodents. Going back to where we started again, on the left, you have autoimmune encephalitis syndromes that are associated with antibodies to intracellular antigens. And on the right, autoimmune encephalitis syndromes that are associated with antibodies to antigens that are on the surface or receptors. Typically, those on the left, the intracellular, they're often associated with more malignant tumors, whereas the ones on the right are often associated with more benign tumors. They can be variably paraneoplastic. In the the first case series of 98 patients that were described, 58 of them had tumors, the other 40 did not. And typically, with the extracellular antigen syndromes, the antibodies are thought of as pathogenic, though these do have to go through a process of being demonstrated, both again through in vitro and then passive transfer techniques. But what about the tumor in NMD encephalitis? I think this is one of the most wild things that's observed in medicine. You have a tumor in the ovary that ultimately leads to an autoimmune process in the brain. And if you resect that tumor early, then the disease abrogates. If you resect it later on, sometimes it can be a bit more challenging. But how? How do you go from tumor in the ovary to process in the brain, to autoimmune process in the brain? And so for that, I want to step back for a moment and think about the process through which antibodies are generated. So let's move away from NMDA encephalitis typically. Typically, you have an antigen-presenting cell, the dendritic cell. It presents an antigen to the T cells in the lymph node, which then become T follicular helper cells, which activate the B cells to generate into plasma cells, which produce antibodies to that specific antigen. This process takes place in the lymph node. In this slide on the left, you have an H&E slide from a patient of mine with NMDA encephalitis. And what you'll see is quite remarkable. In light pink, this is a slice of the tumor. In light pink, this is neuroglial tissue. These purple clusters are organized clusters of lymphocytes whose structure very much resembles that of the germinal center in the lymph node. And in the interest of time, I'm not going to dive into it, but when you look at these clusters of lymphocytes through the lens of single cell transcriptomics and spatial transcriptomics, what you see is they perfectly mirror the architecture of the lymph node, where you have dendritic cells that are presenting antigen to T cells that are activating B cells to ultimately become plasma cells and to produce antibodies. So in the tumor itself, in this ovarian tumor, you have neuroglial tissue, you have NMDA receptors that are serving as the antigen. And then you have clusters surrounding it, almost like mini lymph nodes within the tumor. They're called tertiary lymphoid structures that develop in order to develop an immune reaction to that neuroglial tissue. Now that we've dove into the teratoma tumor, we're going to dive back out for a moment and just talk one more time about intracellular versus extracellular mediated autoimmunity. So again, in the early 1980s and 90s, you had anti-Yos syndromes and others. These were specifically antibodies that developed against intracellular antigens, were thought to be predominantly T-cell mediated in terms of the destruction that took place. This transitioned over to the early 2000s when antibodies to antigens like NMDAR and LGI1, surface antigens or receptors, were discovered, thought to be pathogenic. In order to demonstrate the pathogenicity, though, a series of experiments are typically done, including both in vitro experiments as well as passive transfer experiments to an animal model, demonstrating that with the antibody, with the passive transfer of the antibody, that the syndrome is recapitulated in an animal model. Not all antibodies, though, are created equally. If you look at the left side of this screen, these are just a few of the autoimmune encephalitides that have been described in recent time, and the numbers are growing. On the right, what you'll see is a predominant IgG subclass. So IgG, a structure that we know well, but there are many types of IgG. So IgG 1, 2, 3, and 4. They're numbered based on the prevalence in healthy serum. So IgG1 makes up the majority of healthy serum, followed by IgG2, 3, and 4. They're quite different, though. IgG1 and IgG3 have far more effector function, as you see going down the line. They're better at activating complement. They're better at opsonizing and neutralizing. IgG4 is a bit unique. If we look at IgG4 and its structure, it's bound together by these disulfide bonds, which are fairly weak. And so what happens is you have the IgG4, which breaks apart and recombines with another IgG4 arm. It's called Fab arm exchange. And what that leads to is a bispecific antibody where one side is specific for one antigen and the other side is specific for another antigen. As a result, unlike IgG1 and IgG3, IgG4 cannot cross-link in the same way. So if we go back to this slide in the pathogenicity, while with NMDA, typically you have cross-linking of receptors. So the IgG itself binds with each arm to an NMDA receptor, cross-links them, and then causes them to be internalized. With IgG4, for example, in the case of LGI1 encephalitis, only one of the two arms is specific for the NMDA receptor. So it cannot cross-link and internalize. And instead, what happens is this IgG4 antibody binds to LGI1 and disrupts the protein-protein interactions. Going back to this table, what you'll see is interesting. So in this first set of diseases on the top, and then mGLUR5 as well, and GABA-A receptor, these are all predominantly IgG1 mediated diseases. With IgG1, that means there can be cross-linking and internalization. It means there can be complement activation, and there are effector functions. In diseases like LGI1 and Caspr2, which typically affect an older demographic and skew a bit more male than, for example, NMDA encephalitis, you have an antibody that's an IgG4 antibody. And in this case, IgG4 is not able to activate complement, has poor effector functions, and cannot cross-link. And so predominantly the mechanism of action is interruption of protein-protein interactions. Any questions so far?
I don't see anything in the Q&A yet, but can moderate the Q&A at the end too.
Yeah, fantastic. Excellent. So what does this mean? What does this mean for treatment? This comes from a paper by Delakis where he beautifully summarizes some of the challenges with IgG4 mediated diseases specifically. Many of the treatments we use, for example, IVIG, which was one of the early treatments that was used for LGI1 encephalitis, function through mechanisms like, binding the FC, the neonatal FC receptor and preventing recycling of IgG, or binding to the FC gamma receptors. But these are mechanisms that are specific to IgG1 and don't necessarily apply in the same way to IgG4. Other treatments, like complement inhibitors, for example, would not be quite as beneficial for IgG4-mediated diseases because, again, IgG4 cannot activate complement. So in thinking about our treatments for autoimmune encephalitis, while we think of this category in general as one category, actually the diseases are fairly heterogeneous in terms of mechanism. So intracellular versus extracellular, pathogenic and mediated versus associated, IgG1, again, where you have clear effector functions, versus IgG4, where you have disruption of protein-protein interactions. As we go through and we treat a disease for which there is no FDA-approved treatment, it can be helpful to think about the immunologic mechanisms that ultimately cause the disease. Dr. Lefland, I promised you I'd spend 1 minute on seronegative autoimmune encephalitis, but this is really the next frontier. When I hear seronegative, it's not really seronegative, right? It's test negative, meaning we haven't yet discovered the antibody or the mechanism. And so when you run the test for your hypothesized antibody, it is negative. But these are individuals who have rapid progression of symptoms, so similar to the characteristics required for probable NMDA encephalitis. You've excluded sort of the well-known syndromes. The antibody testing is negative, but you still have objective findings. So either you have an MRI, which has an abnormality, and sometimes that's subtle, as in Sam's case at the beginning. And then you have either a CSF pleocytosis or oligoclonal bands, or you have a brain biopsy that shows infiltrates. And in these cases, a treatment with immunotherapy would certainly be warranted. In addition, I would advocate for the testing of the serum for potential novel antibodies. And that can either be done through your own research institution or through places like Mayo, which will look at serum, for example, to try and identify novel autoantibodies. With that, I'm going to pause, Dr. Lefland, and see if there are any questions.
There is one question in the chat. Why are there seizures when NMDA antibody presents and there's internalization of the receptor? Why does that lead to seizures?
Yeah, it's a great question. And I think to some extent, I think still being fully understood.
That's the only question in the chat right now.
Okay. I'm going to zoom in a bit more on the teratomas then for a moment. So some of the data that you saw earlier was the H&E slide of a patient with an NMDA encephalitis. We took a series of these tumors from individuals with NMDA encephalitis and a teratoma, and we compared them to control teratomas. So teratomas are relatively common. We looked at them and we tried to identify comparable sections, which actually wasn't easy because within the NMDA encephalitis tumors, there were far more both neuroglial tissue and also organized lymphocyte structure. So we matched them in terms of both ensuring that both the control teratoma and the NMDA encephalitis teratoma had neuroglial tissue present on a slice, as well as lymphocytes. And then we analyzed them using two different complementary approaches. So we added probe panels to whole transcriptome probe panels to the tissue, and then each probe pair hybridized to its target gene and was ligated. The ligation products were released from the tissue and bound with spatially barcoded oligonucleotides present on the capture area. And then libraries were generated from the barcoded programs and were sequenced. And what we saw was very interesting. So in the center of the tumor, what we saw were both markers of the NMDA receptor, but also some astroglial markers. This is that area in the center where you had the neuroglial tissue. And then along the outside, what you'll see is CD38 is a marker for plasma cells. And then when looked at with single cell, you see a mature neuron cluster. In the NMDA encephalitis, you see a much more robust B cell cluster, a more robust T cell cluster, and then also an immunofibroblast cluster. When you zoom in on the lymphocytes specifically, so again, the control teratomas had lymphocytes as well, but when you zoom in on them, what you see is that we think of immune checkpoints, right? So what you see is that some of those immune checkpoints are lost in the lymphocytes, or at least downregulated in the lymphocytes from individuals with the NMDA encephalitis teratomas. So for example, PD-1, right? We think of anti-PD-1 therapy in cancer, right? In order to remove the checkpoint or to downregulate the checkpoint and increase the T cell response. Well, in this case, you have a similar response in the NMDA patient. So PD-1 in those cells is downregulated as compared to the control tissues. So just circling back again, on the left, you have a teratoma from an individual. This is the H&E. On the left, you have a teratoma from an individual without NMDA encephalitis. In pink, you have the neuroglial tissue. You have some swarms of lymphocytes, but they're not organized. Individual with NMDA encephalitis, you have neuroglial tissue in pink, surrounded by organized clusters of B and T cells with downregulation of the immune checkpoints like PD-1 within the lymphocytes, generating a response to the neuroglial tissue, which ultimately leads to the autoimmune encephalitis. Dr. Leflin, I'm going to pause there because I don't have any more, but certainly open for questions.
Absolutely. There's a couple of questions already. So Dr. Richardson has a really interesting question. I'm aware of IgG subclass switching, for example, in pan-neurofacin. Is there a role for measuring serum IgG4 levels to help choose treatment?
Yeah, I think that that's a great question. And I think I think that's where the field is going. I think we have more and more of a molecular understanding. So, in each of these diseases, and obviously there's a lot more that's been done in diseases like NMD encephalitis, in diseases like myasthenia, to some extent in NMO and in MOGAD. There's both which antibodies are present and then which are pathogenic. It's been done for LGI1 encephalitis as well. And I'll step back just because the data is better for LGI1 than it is, for example, for neurofasciin. So for LGI1 encephalitis, typically, and most commonly, the antibodies are IgG4. However, There are cases in which there are IgG1 present, and in those cases, the patients tend to have worse cognitive symptoms. There's a beautiful paper by Sarosh Irani that was done mapping out these antibodies. Those patients tend to have worse cognitive symptoms, particularly if the antibodies are identified in the CSF. And so at the moment, there is not a clinical role for measuring the IgG4 versus the IgG1, though I do hope that that is where the field will go in the long term. Great question, Dr. Richardson.
Somebody did add anonymously that it's generally felt that IgG4 levels are not reliable. I'm not aware of that specific information or that specific data. There's another question. Is there a link between NMDA encephalitis and MS? The lesion on the case you described looked very similar to an MS lesion.
Yeah, it's a great question. This particular patient did not have MS, but it's a T2 flare lesion. It's a nonspecific inflammatory lesion. And I think the purpose in showing that case was we've all seen these T2 flare lesions. We've seen them in so many different cases. Dr. Leffledge, you have probably looked at them until, until you could not anymore. But the lesions in NMD encephalitis can be fairly nonspecific. And so, the criteria, for example, for seronegative or for a probable NMD encephalitis are really structured in such a way so as to require some amount of objective evidence of neuroimmunologic disease. But that evidence, can be a bit hazy, like that lesion you saw, which looked like it could be anything.
Dr. Richardson says again that his patient with ulcerative colitis developed autoimmune encephalitis with myoclonus and psychosis, stable now for years on azathioprine. Do you have suggestions on tapering or judgment of permanent remission?
Yeah, absolutely. So, with autoimmune encephalitis, there are cases where patients have a monophasic illness and then they resolve. And so, it really depends. In my own personal experience, sort of anecdotally, my patients who had conditions like NMDA encephalitis in the absence of, for example, a recurrent teratoma were more likely to have a monophasic course, whereas those with the IgG4 mediated autoimmune encephalitides like LGI1 were more likely to have a relapsing course. But certainly if your patient has been stable for years, I think there could be rationale to try and taper the therapies and then to have close monitoring.
Someone says, great lecture. Is there data on how long it typically takes patients to recover after resection of ovarian tumor in NMDA encephalitis?
Yeah, also a really good question. So with NMD encephalitis and the ovarian tumor, there are a couple things that matter a lot. So one is how early you institute treatment. So in theory, if the tumor is resected very early, those patients respond very quickly. But unfortunately, oftentimes we're sort of chasing our tails and the disease is diagnosed later, in which case more immunotherapy is needed. In LGI1 encephalitis as well, and I think this has been demonstrated over and over and over again. There's a 2018 paper, again by Sarosh Irani's group, that demonstrates that really immunotherapy early is what predicts the long-term positive outcomes. And so for NMD encephalitis, what I would say is it's variable. It depends how early the immunotherapy is instituted and how long it has been since the patient first presented with symptoms. In the case of the patient that I mentioned, she initially presented in August. She was discharged to rehab in November. And 2 years later, she still had mild cognitive deficits, like attention and memory deficits. So again, it certainly can be variable. It depends on how quickly it's treated with immunotherapy and how quickly the teratoma is resected.
And that's actually a really relevant question, I think, for our resident group right now, because there's a patient with likely NMDA on service right now who had a teratoma removed last week. So
wow.
Timely lecture. And
how's she doing?
Well, as of yesterday when I left service, she was pretty much the same as she had been and was catatonic, but she seemed to be slowly improving, slowly perking up, becoming a little bit more alert and aware. So hopefully we'll continue to see her improve.
Yeah. Catatonia can be a difficult one. I find that that folks often experience those symptoms as very nonspecific. And it can go in either direction. Either, patients can be sort of staring off into space with a decreased blink rate and their movements can be decreased, or they can be very agitated with catatonia. And so sometimes that can look a lot more like delirium and can be confusing to see.
I think that's a really nice segue actually into the next question, which comes from Michaela, one of our chief residents. She says, thank you. This is an inpatient resident team. Could you speak to the differential thought process you have when considering between primary psychiatric disorders and autoimmune encephalitis at first evaluation? When you begin to consider autoimmune encephalitis when a patient presents to the ED with psychosis?
Yeah, absolutely. This is a really tough one, Michaela. So, and one of the challenges is that we don't have great biomarkers at that first presentation with psychosis. And imaging, as you saw, can be wonky. I mean, if you saw that T2 flare lesion in a normal, healthy individual, would you think much of it? Probably not. And so I think at that moment it can be very challenging. There, a really thorough neurologic exam becomes important. A very clear history becomes important, trying to understand, first sort of the course of the disease, right? In a disease like, for example, schizophrenia, patients often will have, a period of time where they have withdrawal before they develop psychosis. As opposed to with NMD encephalitis, where you have a pretty rapid onset, less than 3 months time, I think is what the criteria say, of psychosis, so that the time courses can be different. Ultimately, you really have to go back to those criteria, though, and try and understand if there are other, neurologic symptoms like dyskinesias, maybe like seizures, and then is there paraclinical evidence, like an LP or an MRI that can help support the diagnosis?
Is there ever purely a psychiatric manifestation of AIE? It sounds like you kind of just went through that, but do you want to go on further? And could our provisional treatments like antipsychotics, benzos, or other medications mask symptoms and delay diagnosis?
Yeah, also a good question. I think oftentimes the neurologic symptoms can be subtle, and it can appear that patients present just with psychiatric symptoms. I had a case of a young man who presented. He was not English speaking, and I think that may have, added to the challenge of the diagnosis. But he presented after a suicide attempt, and was hospitalized in a psychiatric hospital. He had cut his throat, and while he was at the psychiatric hospital, he started arching his back, they thought because of tetanus, but he was seizing. And he was eventually transferred to Yale and diagnosed with NMD encephalitis. But certainly the presentation can be psychiatric in nature. The challenge is that there are far more purely psychiatric presentations than there are presentations of autoimmune encephalitis. And so again, I think in those cases, really having an eye towards what does the neurologic exam show? What does the CSF, what does the CSF show? What does the MRI show become really important? It doesn't mean that there aren't cases where the symptoms are purely psychiatric, but they're far more rare. And if your spidey sense is up and you think something is just off, this is not like other cases, then one can always test. But in general, I would look for, again, sort of demonstration of the symptoms, as outlined in the criteria, and then evidence of paraclinical evidence like CSF or MRI. Not because it doesn't exist, but because the number of cases that are primary psychiatric, if they're only psychiatric symptoms, are far higher than the number that are autoimmune encephalitis.
Similar to another question that we talked about previously, how much time does it take for rituximab to act? If no response, what do you do next?
Yeah, also a great question. Rituximab takes a very long time to So the challenge is you have a patient who's presenting acutely. Rituximab goes after CD20. It's a CD20 monoclonal antibody. And so it binds to, it targets the B cells that are precursors to the plasma cells, wipes out that generation of B cells in the hope that it then doesn't progress to become plasma cells that produce antibodies. CD19 is on plasma cells as well. So does target the plasma cells more directly. And so it takes months for rituximab to really have its effect. And for that reason, oftentimes what happens when patients are inpatient is they may get rituximab to start the process, but typically they'll need some other acute therapy on top of it as well. First line therapies, steroids, IVIG, plasma exchange.
Could you elaborate more on the epidemiology of these autoantibodies among relatively healthy populations? There were earlier reports that it could reach 40%. And how often do we need to worry about overtreatment? Thanks for your great talk.
Yeah, absolutely. Well, since you're going to wait to test your patient until you have met the criteria for probable NMD encephalitis, if you discover an antibody, it is likely pathogenic. There have been reports of antibodies like NMDA antibodies in a healthy population as well. With NMD encephalitis, the antibody titers really need to be positive in the CSF, not just in the serum. And I think that that's an important distinction. We don't typically test healthy individuals for NMD antibodies in the CSF, right? Because we're not doing lumbar punctures. But my guess would be that the prevalence of NMDA positivity in the CSF would be low. It might be a little bit more challenging with a disease like LGI1 encephalitis, where you may see higher titers in the serum as compared to the CSF.
And there's another question, how to diagnose a microteratoma. And I might just add to this question, because I think it's also relevant for the patient mentioned who's on service. What would you do about evaluating for that and potentially treating that in these young, otherwise healthy women who will hopefully recover and aren't able to consent to potentially removing both of their ovaries when they're of childbearing age?
Yeah, the consent piece is really tough, Dr. Lefland. And I think that that's an important thing to remember. So, in the autoimmune encephalitis clinic at Yale, one of the things we really tried to do was to blend immunologic care, neurologic care, and psychiatric care. And I think it becomes really important to remember that in these women, they have gone through it, for some, a very traumatic experience, right? Particularly if they've lost consciousness or not been able to consent and then had a teratoma and potentially their ovary removed. By the time they're seeing you in the neurology clinic, they're sort of now awake and conscious and reckoning with that experience, which they may or may not have any memory of. And so that consent piece becomes very challenging. And I think, from an ethics standpoint, follows the same guidelines that you would use for any other patient who is not conscious or unable to consent, but certainly carries sort of unique emotional and social baggage on the other side as well.
Can you comment on NORS, new onset refractory status epilepticus, as an autoimmune encephalitis condition?
Yeah, I will say Norse is not my expertise, so I'm going to save that for another time. But certainly very, very interesting.
Have there ever been cases with normal CSF?
With normal CSF, do you mean normal set, like no zero cell count, or do you mean no antibody?
Dr. Glad, if you want to add into the Q&A a clarification, but I think she probably means normal cell count protein glucose basic studies.
Yeah. So for example, in NMDA encephalitis, only 80% of the patients have a pleocytosis. So you certainly can have normal CSF. And that again makes those cases more challenging. And then you're looking to either your MRI or your EEG, or this patient has developed both psychiatric and neurologic symptoms, and you've gotten a CSF antibody in your testing.
I think there's one other question in the chat so far. Great presentation. Are there any cases of false positive RT-QuIC in patients with cognitive issues and autoimmune encephalitis to your knowledge?
Say that one more time.
Are there any cases of false positive RT-QuIC in patients with cognitive issues and autoimmune encephalitis to your knowledge?
I'm curious where the question comes from.
The person who submitted that was anonymous, so I'm not sure who asked.
Okay. Well, what I will say is We did have a patient who had NMD encephalitis and positive GFAP and had a positive RT-QuIC. And that was thought to be negative. And I had another patient with DPP4 encephalitis who had a positive RT-QuIC. I never figured out what the connection was, but both were thought to be erroneously positive. So I suppose it is possible, but I don't know what the connection is.
Really interesting. I'll just add one question that I have. There's the trial going on for NMDA with inebilizumab, right, a broader sort of CD19, CD20 agent. But I'm just curious in your own mind where you think treatment is headed, and are there particular targets that we should be looking at?
Yeah, absolutely. Dr. Lefton, I think that this is a really exciting area, and I think that this is an area where there's a lot of room for research to be done. So certainly there are, as you mentioned, inebilizumab, I think is an exciting trial. As I mentioned earlier, rituximab targets CD20, which doesn't target the plasma cells themselves, and CD19, like inebilizumab, has the potential to do that. There are also other therapies in trial for other diseases like felzartamab, which targets CD38 cells, which may be an interesting option down the line in autoimmune encephalitis. At Biohaven, we're working on an IgG degrader, which takes IgG to the ASGPR system for endolysosomal degradation, and removes antibodies through that pathway, with potential follow-on degraders that specifically target antigen-specific antibodies. So I hope that will come through in clinical trial, and the clinical trials will tell down the line. But, again, I think that this is an area where there's a tremendous amount of active research. I think that the more we know and the more we chart out about the disease, I think the more opportunity there is for development of, molecular techniques to target the antibodies. And, NMDA encephalitis and LGI1 encephalitis and the autoimmune encephalitides, they struggle in therapeutic development in many of the ways that other rare diseases do. In that the data is limited, the disease, autoimmune encephalitis, is heterogeneous, but the outcomes that are often used are very rough. So, for example, in the Extinguish trial, the NMDA encephalitis trial, one of the main outcomes that's being looked at is the MRS. Which is a pretty broad measure, right? You have to have a fair amount of disability to score on the MRS. And so really thinking about kind of what the next set of evaluations that we can do, what the biomarkers are that we can use in clinical trial, I think will help the field along as well.
Thank you so much. And thank you for this really interesting talk and the lively Q&A discussion. I know everybody is looking for the CME code that wasn't included in our August list. Dr. Gardin, did you happen to receive the CME code in the follow-up email to scheduling this?
Let me look. Give me 1 second. I don't see it, Dr. Loveland.
I know we're also trying to get it from Crystal, so hopefully
I'm
we can
looking.
email it
Hold
out.
on, let's see. I don't see it here. I see the Zoom link. Dr. Loveland, I don't see the CME code.
No problem.
I'm
We're
still looking
working
though.
on getting it from Crystal. So for everyone looking for that, hopefully that will be emailed out shortly. and everybody will be able to obtain the credit. But thank you so much, Dr. Gardin. Thank you for joining us. And thank you again for the wonderful talk, and have a great day, everybody.
Thanks so much for having me. Take care.